directly acceptable by World Health Organization and the FDA. But I'm happy to inform you that the Gen Hospital, they tested antiviral agents on 104 patients. All of them were cured. 0 death, no infections in the medical staff, and no misdiagnosis. But unfortunately, where you don't have the manpower, you have the liberty of wrongly diagnosing patients that don't have the COVID-19, the coronavirus. You will just say he has it. Just like where we have so many cases on HIV/AIDS. Nobody has the HIV, but in the lab, they will tell you that you have it. Then after some weeks, you come back, they do it again, they will say you don't have it. But before that week, if you are 110 kg, before the week you come back to maybe 60 kg, you'll be down. In Nigeria, the manpower also. I know some guys were sent outside for training, but the president directed that they should come back. Professor Tigan, we have several labs now. One has been activated today. That is Abakaliki. And in the next 3 weeks, they want to have labs in Kano, Sokoto, Jos, Kaduna, Maiduguri, Takot. So in the next 3 weeks, we want to have 13 laboratories. But again, I had the DG of National Center for Drug Disease Control saying that they still don't have the manpower to man on the laboratories, all the laboratories. But they are appealing to Nigerians. So many people are rushing to the labs to be tested without any symptom. Don't go if you don't feel unwell. And many people, even if they have the coronavirus, they don't seem to show that they are sick. And in UK, they said 50% of those who have coronavirus, they are immune to it. They have not shown any symptoms, and they don't think it will kill them. So it's not a death sentence. But unfortunately, in Nigeria now, because if the antivirals are not working, it's expected to use what they call hydroxychloroquine or chloroquine. This is on compassionate use. Just like the President of America said, please allow us to use hydroxychloroquine or chloroquine phosphate on compassionate use. And WHO, FDA allowed that because they have their own protocols. They have to follow the protocols, they have to conclude before they give you the approval. In Nigeria, chloroquine has been banned because of the resistance to malaria. But now DG NAFDAC said they are going on clinical trials to see if it works. Then they will allow it to be used. But globally, it's allowed on compassionate use. I see no reason why Nigeria cannot do it.
Thank you very much.
Thank you.
Thank you. Excellent one. I'll come back to you on the, the extent to which the pharmaceutical dimension, is, and of course, like I said, Dr. Okele, I will return to you on the level of manpower, capacity that, required, the gap, and what is required to quickly, build the capacity required to attend to the crisis moment. On this note, let me invite Engineer Ukundari, maybe for an engineering angle.
Thank you, Mr. Chairman. Fellow discussant management, good morning. For me, there are two key issues. The first one is the institutional capacity. For me, two things are critical. Number one, institutional capacity. How are we set up as a nation to be able to respond to issues like this? I remember that earlier in this course we talked about national resilience. From what has played out in this virus issue, it appears came up. Virtually, we don't have the medical facility to arrest the situation. Otherwise, from I think February 27, when the first case was noticed in Nigeria, if there had been prompt and efficient management of the issue, I don't think we get to. I think by last night we are 111 or so in the country, and an affected person gets to that locality, you can be sure that everybody in that place will be infected. Because for about 2 weeks of recording the first case in Nigeria, there are still parts of Nigeria that are saying they don't know. So institutional capacity to manage it and then to disseminate information is very, very lacking. States are doing their own. The federal are doing their own. There's no concerted effort. I think it's very, very important. Then the second issue for me is research and development. Research and development. Now, like the pharmacist said, we are waiting for other people to do research and then come up with the solution, the virus, the vaccine against it. But internally, as citizens of this country, as professionals, as medical people, what are we doing? There's no research going on. Nobody is doing any research in Nigeria. So we are just playing a waiting game, waiting for other people to develop the vaccine, and then we start running over the place.
It's a crisis situation.
Yeah.
You can't give what you don't.
Yeah, I agree that you can't give what you don't have. But if you know that you don't have something, then you cannot perpetually be on the mercy of others. You must do something. As a nation, we have the resources, we have the people that can do it. We have Nigerians that when they leave the shores of this country, they are performing out there.
Okay, I'll come back to you on the research. I'm sure some other people would contribute. Okay, some people are already reacting. Yeah. Now let me go back to now. It won't be in the sequence. Oh. No, I have no reason to forget Amina. Okay, so Amina MON.
Thank you very much, Mr. Moderator. Good morning, management and everybody. So I have very, very few points here concerning the social services. I want to mention first the access to health care. And I want to ask a question. How many of us deep down believe that we have only 111 cases of COVID-19 in Nigeria? I don't think that's a true picture. I believe there's information that is being hidden from us, because you don't even have test kits. And this thing, like any other thing in Nigeria, is taking a political dimension, because only high-profile cases are reported. Out of 111, we know very high-profile, governors, chief of staff, big people. What about the rest infected, those that tested positive? I think there's need to really come out and be honest and transparent at this critical point of life. You find we're really lucky, because I think many that may have been infected, maybe we have mild symptoms, and I think we have some kind of immunity. The culture of Nigerians is when you're sick, you just go to the chemist and buy drugs, get injection. Unfortunately, the symptoms of COVID-19 is similar to malaria. You know, you start with a cough, you start with high temperature, and I think before you know it, you get treated and you're cured. So I believe there are so many infected persons with COVID-19 that they don't know, because they can't even go to test. And then there's this stigma, you know, like you test positive, and it's just like you're having HIV/AIDS. You know, people run away. So because of that stigma, I know, because if one of us now is tested positive, I can assure you will not be sitting here. We'll all be running helter-skelter and running, you know, to hide ourselves. So the workforce, sir. Yesterday, the president in his speech, he mentioned the strategies that they're taking 2 steps. One is the social distancing, and the other one, he said, to preserve and protect the livelihood of Nigerian workers. How do you do that? How? You have shut down borders. Someone mentioned about overreacting, that we can overreact. I don't think we should overreact. What is the business of Sokoto closing its borders, sir? And Kebbi? And Katsina? Why? You don't have a single case there. Some are even imposing just 10 people in a room. How do we enforce that? So this is an issue that we really have to look when we're looking at our recommendations. How to make housing affordable and a good one. Education, we are having issues also there. Schools have closed. They said an idle mind is the devil's workshop. So what do? Advanced countries, they're doing e-learning. You're at home and then you're learning. So it's not as if you're missing anything. We have not reached that level. Someone mentioned that the civil service can run on Skype. How? Where is the power?
Okay. Thank you very much.
Sir.
Amina. Is somebody that know you that can do it? Okay. I can see us running against time. We are given only 1 hour. 1 hour, 15 minutes. Oh, okay. So we have, okay, we still have about 20 minutes. Is that right, sir? Okay. I'd like us to put a finger on the governance. And I see that Professor Paramalam started that conversation. Do you want to get back to it? Not so much in terms of diagnosis now, in terms of what's working, right, what's not working, right, and what needs to be done.
Maybe probably more of what can work, so what that we are actually realistic.
And the area of resource gap and resource mobilization.
Thank you, Chairman. I think the first thing that needs to be said in the area of governance is that when we speak about governance, people often think of the presidency, or they think of formal structures of governance. So when we say, oh, we're looking at COVID-19 and governance, we're looking, okay, so what can the presidency do? What can state governors do, and all of that? But we have to understand that we have a diffuse and comprehensive governance system, which means that government, the formal political government, the state, has assets beyond just itself. So for instance, traditional rulers, religious rulers, even governance at the family level. These are governance structures that we need to draw upon now and very effectively. So I just want to set that tone by saying, when I talk about governance, I'm not just talking about the presidency. We acknowledge that the presidency has deployed certain assets already, and that, for instance, there are economic stimuli. But if we want to talk about resource mobilization, I want to talk about it in terms of 3 things. 1, prevention. 2, preemptive action. 3, treatment. And I'm still talking about resource mobilization. So in terms of prevention, the first issue is tracking. And I think somebody alluded to that earlier. We know that the government is trying to track over 4,000 cases, okay? Potential cases of COVID-19. So therefore, we need to have in place a proper and effective tracking system. How can we do that? We know that, like engineer said, institutional capacity-wise, we have a disjointed and a disjunctured healthcare sector governance system. But we do have community leaders. We do have religious leaders. We do have traditional rulers. These can be mobilized. They can be engaged. They can be educated, enlightened to recognize symptoms and to train their memberships to recognize symptoms and set up a reporting system through these informal systems of governance. That's one asset that we have in our communities that we need to begin to mobilize. The second issue is the issue of water. Very basic, but very essential. So some countries, like China in the rural areas, set up makeshift water outlets and particularly mobilize women, rural women, to be custodians over those makeshift water systems so that people can have access to water. Now, because that water is so basic, so elementary, but so critical when it comes to the management of